and a very warm welcome to a masterclass in multiple sclerosis hosted by the University of Colombo Clinical Society in celebration of World Brain Day 2021 in collaboration with the Association of Sri Lankan Neurologists and the Multiple Sclerosis Association of Lanka. This is a 2-hour program consisting of an overview of multiple sclerosis, touching on fundamentals of the disease, its cause, and treatments available. This would be followed by a series of case discussions, after which we would be opening the floor for questions. This would be followed by a short presentation on the functions of the Multiple Sclerosis Association and what it does. Our resource persons today need no introduction. We have Dr. Bimsara Senanayake, consultant neurologist at the National Hospital of Sri Lanka, and Professor Enoka Corea, professor in microbiology and president of the Multiple Sclerosis Association of Lanka. Firstly, to start off today's proceedings, I would like to share a short video detailing the story showcasing a patient's experience with multiple sclerosis.
Good morning, ladies and gentlemen. I'm Dr. Hitayashi Veerapon. I have been diagnosed as having multiple sclerosis. I'm married and have 2 children, aged 18 and 16. I call them my life pocket sticks because of the unstinted support they give me. My husband, Ravi, of course, continues to be a tower of strength to me and has made sure that I'm provided with all I need. I'm indeed grateful to him and the children because they understand my difficulties and are ever ready to make allowances. As for my illness, I now recall mostly symptoms of my illness when I was 24 years old. Occasionally, I experienced numbness in my feet. I also experienced periods of numbness in my face. Each of these lasted for about 2 weeks and settled. I just assumed they were psychosomatic and never considered it was due to a neurological illness condition. While reading for my master's in community medicine, I had difficulty coordinating fine movements of the hand. In 1996, following a minor car accident, I decided to seek medical attention at the age of 34. When diagnosed with this illness, it was a sense of depression. I tried my best to ignore my illness and carry on with my life. Intense fatigue was troublesome and got me down. It was quite frustrating when I couldn't drape my sari, button my blouse, or even comb my hair. I did not share these thoughts with others, as I felt they may not have understood what I was going through. I felt lost and alone. The category of MS I had was a secondary progressive type, and soon I had to terminate my work at the University of Fairfield. I began to realize and understand that this was not going to be the end of my life, but a new way of life. I had to make changes to make things easier for myself. My husband arranged for railing to be fixed on the wall to enable me to go about safely. As I had a problem with balance. I had to plan my daily activities at times when I was not fatigued. And I learned to do most things while seated, mainly in order to save energy. The frequently used articles were kept within easy reach in my home. I also had to plan my daily activities around many regular periods of rest. To overcome fatigue, I had to save my energy. To do the most essential tasks, and I would only do them when my fatigue was at a minimum. When I realized that having MS does not mean that life should fall apart, I was determined to share my experiences and encourage other patients with MS. That intention of helping other patients with MS to improve their quality of life was the main reason for forming the Multiple Sclerosis Association of Lanka. I felt the need to raise awareness of the disease itself and the problems faced by the patients, providing physical, emotional, and financial support to patients and their families and caregivers was some of our key objectives. Early diagnosis is important to implement the therapeutic strategy. However, there are patients in rural areas of Sri Lanka who have limited access to necessary information and the symptoms. More diagnostic procedures involving MRI and or lumbar puncture are offered in a few centers, and this may lead to a delay in diagnosis. There is social stigma associated with this disease. Many do not acknowledge the condition. Others keep the illness secret. Some keep the patient with MS feelings, and some attribute the illness due to sins committed in the past life. We strongly feel these attitudes have to change. In my capacity as president, I have interacted with several patients across the country, and we now have 84 patients diagnosed with MS in our association as members of our association. We hope that neurologists and other medical professionals who encounter patients with MS will make them aware of the existence of the MS Association, enabling them to interact with other patients with MS and support and facilitate provided by the MS Association. We need families not to give up on their loved ones with MS, thinking there is no hope. Adapting to life with MS may take time, but with a positive attitude and appropriate health care, one's quality of life can improve. We want people with MS to get the most out of life and to hold their heads up with dignity. So I would appeal to all of you to support our cause. Thank you.
Next up, we have a short video, a message from Prof. Tissa Wijeratna, the chair of World Brain Day 2021 at the World Federation of Neurology.
Hello, everyone. Greetings to all of you on behalf of World Federation Neurology World Brain Day team, public awareness and advocacy team, representing World Federation Neurology as well as Multiple Sclerosis International Federation. We are delighted to be able to share a few words with you on this historic occasion. Congratulations for the Colombo Clinical Society and organizing committee, everyone who put their blood and sweat to put this together, to rally all undergraduate students encompassing all universities across Sri Lanka to be part of this campaign, 8th World Brain Day, Stop Multiple Sclerosis. You might wonder why we should care. It's no brainer to think that it is our brains which makes us who we are today. I am talking to you and you are trying to understand me thanks to our brain and behavior. One of the fascinating story today that I would like to share is the enormous advances that we made in this enigmatic disorder, multiple sclerosis. Multiple sclerosis is a disorder that affects close to 3 million people worldwide at this point of time. The mean age of diagnosis is 32 years of age. As you could imagine, at the age of 32, it is such a prime age that most human beings would be thinking of their marriage, building up a family, building their first house, so on and so forth. Imagine that you get a devastating disease affecting your brain at that age. In fact, once every 5 minutes, someone somewhere get this diagnosis. The good news story is the therapeutic advances that we have at this point of time to treat multiple sclerosis is immense, to the extent that you could almost stop multiple sclerosis. The aim of the game in 2021 is to push the potential disability as further as possible through early diagnosis and early treatment. The sad truth is 70% of the countries, including Sri Lanka, or most parts of Sri Lanka, is unable to access early diagnosis or high quality treatment to this disorder. This is one reason that World Federation Neurology is running this ambitious campaign to stop multiple sclerosis as a massive global advocacy campaign. I would warmly invite you all to join this campaign and support us by visiting World Federation Neurology website, clicking on the icon World Brain Day, and downloading the World Brain Day toolbox. We have created the slide deck, large number of social media kit, variety of video collection that you are most welcome to download and share in your social media platform. Log on to your Facebook, Twitter, LinkedIn, Instagram, and type hashtag World Brain Day 2021, hashtag Stop Multiple Sclerosis, hashtag I support World Brain Day, hashtag I support brain health. There's no health without brain health. Please continue to support Colombo Clinical Society and this historic initiative and rally around World Brain Day to stop multiple sclerosis. Take care, stay safe, and stay well. All the very best on behalf of World Brain Day team, World Federation Neurology, Multiple Sclerosis International Federation. Stay safe and stay well.
Good morning, ladies and gentlemen.
Ladies and gentlemen, I would now like to invite Dr. Bimsara Senanayake to take us through this fascinating disease. Over to you, sir.
Can I start? Thank you very much. Thank you for inviting me for this presentation. I must thank the Colombo Faculty Clinical Society for inviting me today to talk about multiple sclerosis. Right. So, as was mentioned earlier, 22nd of July every year, the World Federation of Neurology celebrates the World Brain Day. And there are different themes picked for each of these days, like every year, the 22nd of July. And this year, it was decided to have the World Brain Day on multiple sclerosis in collaboration with the Multiple Sclerosis International Federation, MSIF, which is a global network of 48 multiple sclerosis organizations of people affected by MS and volunteers and staff around the world, whose vision, of course, is a world without MS. So that's the importance of the 22nd of July. To briefly go through what multiple sclerosis is, it's a chronic disabling inflammatory demyelinating disorder of the central nervous system, affecting the brain and the spinal cord and optic nerves. Myelin is produced by oligodendrocytes, as you know. And in MS, the myelin is attacked by immune-mediated, it's an immunological process leading to demyelination with the formation of the so-called demyelinating plaques, which appear in the spinal cord, brain, and the optic nerves, causing these various symptoms. So it usually happens as a result of the T cells gaining entry into the brain through the disruption in the blood-brain barrier and recognizing myelin as something foreign and starting to attack it. So thereby causing destruction and demyelination in different parts of the brain, spinal cord, and the optic nerves, which results in these different types of symptoms that these patients get. So these are the typical plaques that you might see as a result of this demyelinating process, which are forming in the brain in certain specific sites, interestingly, which makes them different from some other white matter lesions that you might see in different disorders. And these lesions, the demyelinating lesions or white matter lesions, you might see in the brain, spinal cord as multiple short segment lesions, and also in the optic nerve. So these are the three key sites at which these lesions starts occurring when this disease process takes place, which results in the different symptoms that the patients get. So the key pathological hallmark would be this plaque, which appears in the central nervous system. So going back in history, this condition was first described by Jean-Martin Charcot, a French neurologist whom we consider to be the father of modern neurology, who had described most of the conditions in neurology, modern day neurology that we talk about. So this was no exception. So Charcot in 1868 sort of discovered this disease and named it as well as a disease with these plaques. So Charcot, of course, is everywhere in neurology and also in medicine. So he's well known. He's a giant in the field and also in medicine in general. So he's the one who's credited with describing this condition initially. So the interesting finding or feature of this disease because it's having this characteristic or striking geographic variation, with the prevalence being different in different parts of the world. So this is very interesting because when you go through other neurological diseases, we know that the incidence and prevalence might be the same all over the world, even if you take movement disorders, epilepsy, stroke, and so on. We believe the prevalence rates are pretty much similar all over the world. But when it comes to multiple sclerosis, for some reason, we believe that it is common in certain parts of the world, in temperate zones, both in the northern and the southern hemisphere. And also there is a latitude gradient, which is also striking, and it is statistically significant as well, with lower prevalence seen in countries closer to the equator, like our country. And in general, it is thought that in Asia and Africa, the MS prevalence rates are lower compared to Northern Europe and North America and so on. So this is a striking difference when it comes to the prevalence rates. Of course, now this is increasingly being challenged because this could be due to underreporting and being as a result of underdiagnosing this condition, which is not easy to diagnose. You will understand as you go along. So MSIF launched the third edition of the MS Atlas in September last year, and the previous one was 2008. And according to the MS Atlas, now the number of people living with MS has increased globally in every region. Every region it's increasing. So as this just mentioned, every 5 minutes, someone is diagnosed with this condition. And typical age of onset is usually between 20 to 30 years. Globally, it is thought to be 32 years, but in Sri Lanka, we have found in our cohort, it's about 29 years, and at least twice common in women. So there is the female preponderance. So about 2.8 million people approximately are affected by this disease all over the world. This is a clear increase compared to the 2013 levels we got. And in the US, about 400,000 people are approximately affected with this. And Australia is interesting because Australia has a population which is pretty much similar to Sri Lanka, about 22 to 23 million people. And about 0.1% of their population are having MS, like 23,000 patients. So we believe, according to the MSIF, of course, we don't have a good prevalence data here yet. However, we believe that we have anything between 1,500 to 2,000 cases of MS. Some of them are definitely not diagnosed. They must be somewhere in the population with different symptoms. Some have been missed over the years. So comparatively, Australia with the same population obviously has a higher number of patients. So MSIF also recognizes that globally at least 1 in 3,000 have MS, and in high prevalent countries it could be as high as 1 in 300. So also it is somewhat, although it's uncommon in children, people under the age of 18, about 30,000 worldwide may be having this disease. It's not a common disease in children, but children also can get affected with MS. And in our cohort, we have about 10 patients, young children, affected by this disease who are all below the age of 18. So as I said earlier, the prevalence rates are rising all over the world, in all different parts of the world, in different continents. So there is a clear increase in the absolute increase in the prevalence rates compared to 2013 MSIF data in the Atlas and now. So in Sri Lanka, we reported the first cases in 2001, about 20 years ago. These are the first cases which we reported at the time, which we followed up in the latter part of 1990s and reported it in early 2000, 20 years ago. So since then, over the last 2 decades, we have seen that there's a huge expansion in the number of neurologists in this country. There was a time that the whole country had only one neurologist in the 1970s and early 80s, also up to about 81. So now we have about, I think, 45 board certified neurologists in the country and about 20 in training who will be board certified soon. So neurological services have expanded a lot, and the imaging facilities were first introduced to Sri Lanka in '95, the MRI facility, initially to a private hospital, then here at National Hospital. So that has also expanded vastly. So we have the ability to scan these patients. And of course, most importantly, there is greater awareness, because those days, a lot of people thought this disease doesn't exist in Sri Lanka. This was not taught in schools, med schools, and so on. Now things have changed. So the clinical society wants us to talk about this disease, and we see a lot of patients with this disease. So obviously there's great awareness, especially amongst the medical personnel, because there was a feeling that maybe this doesn't exist in this country. So we have done a lot of work to get this awareness across, especially with the eye surgeons, and also to get these patients insurance cover, because the insurance companies did not cover this disease, saying that it may not be existent in the country. So at that time, I'm talking about 25 years ago. Anyway, so apart from that, of course, we have established the Sri Lanka Committee for Treatment and Research in Multiple Sclerosis and Related Disorders. This is in line with similar organizations around the world in the European region, American, and of course the Pan-Asian Committee, which is closest to us. So we launched this in 2019, and we have had 2 international meetings, one large physical meeting which we held in 2019 with many like-minded people, top scientists from all over the world who are pioneers in this field. Attended this meeting, and we managed to launch this committee, and of course we had a very vibrant session followed by a lot of social activity. Of course, the last year, I think I can see Dunya also in that. Yeah, one of my senior registrars who's comparing that day. Anyway, so last year, of course, with the COVID situation, we had to have a hybrid meeting, but anyway, we still had a physical plus a hybrid virtual meeting. Right, so that is about slick SLC trims. Then, of course, we have a collaboration with the Mayo Clinic in the US, with whom we have been collaborating for the last 8 years or so. And we have been using their services to test our patients with certain specific antibodies, aquaporin 4 and MOG, which you'll hear about later on. And also we have links with the European Charcot Foundation and the PACTRINS, as I mentioned earlier. And the Sri Lanka or MS Society of Lanka, as Hitaishi said earlier, which was formed by actually Hitaishi. It's a patient group which has helped a lot of patients, and current president is Professor Enoka Corea, who will be talking to you later on, I think. So I think they have done a marvelous job trying to help these patients to look after their needs as a patient group. Right, so now we'll come to the discussion proper. So how are we going to diagnose this condition? It's a difficult diagnosis to make, so therefore it's underdiagnosed, underreported. So there is a high degree of need for a high degree of suspicion, as which was very clearly seen in the case of Dr. Hitaishi Veerappan. So initial symptoms are attributed to various things, but ultimately turned out to be MS. So symptoms vary and unpredictable. They depend on the location of the plaques and could range from fatigue, numbness, paralysis, loss of vision. Cognition can get affected sometimes. And of course, the characteristic feature is the episodic nature of the disease. So it's not one progressive illness in the majority. So the majority, they have symptoms coming and going, which we call relapsing and remitting. So that episodic nature is very characteristic of this disease. There are some classic MS symptoms like sensory loss, paresthesia, paralysis, monoparesis, hemiparesis. Sometimes can mimic a stroke, spinal cord syndromes, acute transverse myelitis. It could be recurrent also, acute painful uniocular visual loss, and it's optic neuritis, which can be recurrent as well, cerebellar syndrome, ataxia, trigeminal neuralgia or facial weakness, which could be bilateral sometimes, and bladder involvement, heat intolerance, fatigue, pain, cognitive problems, depression, and so on. So you can see it's a wide array of symptoms, different symptoms, which can appear from time to time. So it's not one specific thing. So it's not an easy thing to think of this condition when it occurs initially. However, it's important to suspect. So they can be highly variable, as I mentioned. So usually in a young patient, usually female, especially female, unexplained relapsing neurology, recurrent numbness, weakness, ataxia, brainstem symptoms, painful visual loss, spinal cord symptoms, please think of MS. That's important. That thought is important. The problem is that because sometimes if you don't think, they go unnoticed and they keep recurring, and to a point that they will be quite disabled by the time they see us. So there are many clinical events, acute demyelinating syndromes. Now we talk about coronary syndromes, acute coronary syndromes. Similarly, we can say these are acute demyelinating syndromes, where these events, to be an event, should last for more than 24 hours. That's important. It should be there, sustained. It should not just come and go in 1 hour. So it should last for more than 24 hours. So the events can be optic neuritis, single episode, unilateral, bilateral, sequential, usually sequential. Simultaneous bilateral optic neuritis is usually not seen in MS. Recurrent limb numbness, weakness, acute cerebellar or brainstem syndrome, transverse myelitis, single episode or recurrent transverse myelitis, unexplained fatigue, which is another common symptom, Lemith sign, also known as Barber chair phenomenon, Uthoff phenomenon. So bilateral internuclear ophthalmoplegia, trigeminal neuralgia, and bladder problems and sexual dysfunction. So some of these features mentioned here, these are the events that the patient can come with. So it's important to recognize these events and consider this diagnosis. So what are the, now collectively, if someone comes with these events, we categorize them as central nervous system demyelinating disorders, idiopathic demyelinating disorders of the central nervous system, or CNS-IDDs. So collectively, they are lumped into one. Many years ago, 2 decades ago, or more, maybe 15 years ago, they were all lumped together into this diagnosis of MS. But now we know that they are not MS only. There are other conditions which can mimic MS. So it is important to separate it out. So what are the tools we have to do this? When someone comes like this with these symptoms, you think about MS, think about CNS-IDDs. So what are the tools that you have to sort this out? Neurologists, of course. So the first thing you need specialist input here, because this is a difficult condition to diagnose. It's not easy. So it is best left for a neurologist to diagnose this condition because it's not an easy condition to diagnose. So a thorough clinical assessment is done by neurologist uh, when a patient presents like this. So fortunately, as I told you, all 9 provinces in this country today have neurology units in the government hospitals, manned by neurologists, well-trained neurologists. So they are more than capable of making this assessment and coming to this initial diagnosis of this condition. And then, of course, we need MR imaging. So MR imaging is not available everywhere, but it is available in the country in most places now, most big centers in the government sector and private sectors. So it's easily accessible and compared to 2 decades ago, where we had only 1 or 2 machines for the whole country. So then, of course, the CSF, the cerebrospinal fluid evaluation for oligoclonal bands. This is done in a special way, looking for this intrathecal production of this protein called the oligoclonal bands. So this is done with this method called the IEF method, or isoelectric focusing method, not the normal gel electrophoresis which you do, in order to pick up the intrathecal production. It is important that the CSF and the blood is tested at the same time, because in conditions such as SLE also, you might see oligoclonal bands in the CSF. But in those patients, they also have oligoclonal bands in the blood at the same time, which we call mirror bands. So if you have mirror bands, that's not MS. So the band should be only in the CSF. And the number of bands also might be important. It should be roughly more than 2 bands, but sometimes it can be even up to 10 bands. Then, of course, we assess the anterior visual pathway. As I said, the vision can get involved here as well. So anterior visual pathway has to be assessed using what is known as visual evoke potential. It's an electrophysiological test with which we can evaluate them. Then advanced serology with tests for various other mimickers of MS, which I mentioned earlier, aquaporin 4 IgG or MOG IgG. These are specific antibodies for various different conditions, CNS IDDs, which are not MS. So this is important because now we have the capability of doing that here through this collaboration with Mayo Clinic in our National Hospital Neurology department. However, it is not universally available in Sri Lanka, but we have that ability, and we have been testing. Already we have tested about 1,700 patients with CNS IDDs with both these antibodies. So it's an ongoing collaboration. So hopefully they will continue to do so, because it's expensive to test these with the highly specific cell-based assays, which is done by the Mayo Clinic in the US, which actually were responsible for the discovery of these antibodies. Then, of course, since we don't have a specific biomarker here for MS, we have to go for diagnostic criteria, which are a set of signs and symptoms tests developed for the use in routine clinical practice to guide us to diagnose and also to care for individuals. So diagnostic criteria in any disease is needed for such situations. For example, in SLE, so we have a set of criteria. So we go by those criteria, since one single test is unable to diagnose or exclude SLE. Similarly, in MS, we have different sets of diagnostic criteria. So in MS, the physician must find evidence of damage in at least 2 separate areas of the central nervous system, which include the brain, spinal cord, optic nerves, and find evidence that the damage occurred at different points in time, which we call dissemination in time and dissemination in space, whilst ruling out all other possible diagnoses. That's a difficult thing, that there can be so many other conditions which might mimic it. So the biomarkers in CNS IDDs, the very first biomarker was discovered in 2004 at Mayo Clinic, USA, It was a landmark discovery. It's a huge medical discovery. With this disease, um, neuromyelitis optica spectrum disorder can be now specifically diagnosed, and it can be completely separated out from MS. And these aquaporin 4 antigens were found at astrocyte food processors near the blood-brain barrier. And this antibody test enabled accurate diagnosis of MS and NMO, separate them out. And as I said earlier, NMO, or neuromyelitis optica spectrum disorder, is often misdiagnosed as MS. It's important to distinguish these two because treatment used for MS can be detrimental for patients with NMO. So 1/3 of these patients who have symptoms and signs suggestive of NMO may not have this antibody, and they have another antibody called MOG-IgG. Actually, we have had a large cohort of patients who have this second antibody also in our set of patients. So in the absence of a specific biomarker, diagnosing MS can be challenging. So you need to have these criteria and go by them in order to make a reasonable assessment and come to a diagnosis. So early diagnosis and treatment of patients with MS obviously will alter the disease course and slow the disability progression. The need to improve the diagnosis for initiation of these new treatments that Tissa was talking about initially, to monitor patients. So it's all very important to come to an early diagnosis so that we could start treatment early to prevent long-lasting disability. So the criteria, of course, evolution, if you go by what was there in the past, it started with the very first one was actually Schumacher criteria, which is not mentioned here, followed by Poser criteria, and the McDonald criteria, which were developed in 2001, 2005, 2010, and 2017. So when we wrote up our first cases, we were between Poser and McDonald 2001. But yeah, so we were able to, they definitely satisfied Poser criteria at the time. So some of these initial early criteria were largely symptom-based, for example, Schumacher criteria. But with Poser criteria, VEPs and CSF findings were also included. So then this evolved, as you can see here. 1868 was initial diagnosis or initial description by Charcot, followed by Schumacher's. In the 80s, the Poser criteria, then the McDonald evolved up to 2001, 5, 10, and now 7. So that's how these criteria evolved. So this is Ian McDonald, who was a neurologist at Queen's Square Hospital for Neurology and Neurosurgery in London. He's actually a New Zealander who migrated to the UK and worked in the UK for many years. And he was professor of neurology at Queen's Square until his retirement in 1998. And he's responsible for this new set of criteria, which are known as the McDonald criteria, which was developed in 2001. And it had been revised in 2005 and 10 and 17. So the current criteria which we use is the so-called 2007 revision, 17 revision. So as you can see here, so the clinical attack is still important. If you have more than 2 clinical attacks and objective clinical evidence of more than 2 lesions, still you can make a quick diagnosis. But what is important with these revisions is that early diagnosis is now possible. With even 1 lesion, you would be able to make or rather 1 clinical presentation, sorry. With 1 clinical presentation, you don't have to wait for a second clinical presentation. With 1 event, you can make a diagnosis by using the MRI as a surrogate. So that's how it keeps evolving. And now, as you can see, the comparison is given in this slide. between 2010 and 2017 criteria. And interestingly, in 2017, the CSF has been reintroduced into the criteria. So we take CSF oligoclonal bands as an important feature to say there is dissemination in time, additional information. So that is important. So this, again, the revised criteria of 2017, basically showing you the same list of things that you go through. Just to impress upon you the change, how it has changed. Now, this is a 27-year-old woman who presented with numbness and paresthesia from the right side of the trunk down to the right foot, lasting for about 10 days, followed by the limit phenomenon. That is when you bend your neck, suddenly you get an electric shock-like feeling going down your arms and legs. Sometimes that's called Lemmit's phenomenon. And wrist reflexes in the right lower limb. All the bloods were negative, including ANA, ANCAs, and dsDNA, antiphospholipid antibodies, and also aquaporin 4 and MOG antibodies were negative in this case. So it is a 27-year-old woman, numbness and paresthesia, lasting for 10 days. So they did a MRI on this woman. As you can see, there is some T2 hyperintensities in the body of the corpus callosum, left splenium, left peritrigonal area, cord lesion, thoracic, and no enhancement with GAD. So in CSF, there is unmatched oligoclonal bands. So there is band, oligoclonal bands. But with the 2010 criteria, this patient yet does not fulfill enough for a diagnosis of clinically definite MS, whereas using the 2017 criteria, you could make a diagnosis of MS straight away. Because as you can, it's, I think, pretty evident that the dissemination in space and dissemination in time is taken as positive here because oligoclonal bands also come into play. So with 2020 criteria, patients like this were diagnosed as clinically isolated syndrome, single episode. And so there was a large number of them. But with the current criteria, that number has fallen, and most of them are now increasingly becoming MS. So the other picture over the right-hand side shows that in MS, as you can see, aquaporin 4 MOG antibodies are negative. Cerebrospinal fluid oligoclonal bands are positive in a large number, about 80%. Neuromyelitis optica, aquaporin 4 is positive, MOG negative. That is NMOSD aquaporin AQP4 type. And oligoclonal bands can be there, but much less than in MS. MOG antibody is positive in cases of MOG antibody associated CNS demyelination. Rest are negative, and oligoclonal bands are also not seen in many of them. So that's important because these three conditions, MS, neuromyelitis optica spectrum disorder due to aquaporin 4 IgG, and the third condition, MOG antibody associated demyelinating disorders or MOGADs, they can be very similar to each other in their presentation, but it's important to separate them out. So the antibodies does help. Since we have serology, specific serology for the other two conditions, we would be able to make this distinction. However, having said that, there are seronegative cases of aquaporin 4 and MOG disease. So there can be serious consequences of a wrong diagnosis, because if you treat patients thinking that it is MS with drugs that are used to modify the disease in MS. If the diagnosis, the actual diagnosis is not MS, the patient might deteriorate, might get worse. So in such cases, you might get flare-up of the disease and more lesions in the brain, which will make the condition worse. So that's the importance of testing these antibodies in these cases. So the clinical subtypes can be relapsing remitting, which is the commonest one. 85% of them are relapsing remitting, so they get better after a while, maybe with treatment with methylprednisolone, steroids for the acute attacks. Anyway, they get better. Then, of course, some of them might have progressive symptoms, getting better, but again, there's accumulation of disability and progression, and some of these progressive cases might relapse while progressing, and some of them can be primarily progressive from the very beginning, about 10% of them. That's a rare subtype of MS, fortunately, because we don't want to have that one, which is difficult to manage. So relapsing remitting, total or partial recovery with no apparent disease progression in between episodes of acute worsening of neurological function. Then primary progressive, steadily worsening from the very beginning. Secondary progressive, initially relapsing remitting, becomes steadily progressive later on. But some of them can still continue to relapse, which are called progressive relapsing. So then we go into the MRI findings in MS. MS diagnosis requires objective evidence of lesions. So MRI plays a huge role in the diagnosis of MS. So it can both tell us whether the lesions are disseminated in space and time. So the typical distribution of these white matter lesions should be studied. And the typical lesions could be in the corpus callosum, the U fibers, temporal lobe, brainstem, cerebellum, spinal cord, optic nerves, and so on. Right, so these are some of the typical findings. So you can see some lesions, periventricular lesions abutting on the lateral wall of the lateral ventricle. So multiple lesions adjacent to the ventricle, they should be touching the ventricular wall. Ovoid lesions perpendicular to the ventricle. Multiple lesions in the brainstem, cerebellum. So some of these lesions might be, as I said, perpendicular to the lateral wall, which are known as Dawson's fingers, named after pathologists who did pathology on these patients about 100 years ago. So those are called Dawson's fingers. So where these lesions occur is important. Based on that, you would be able to make a deduction. So gadolinium enhancement is seen in T1 weighted images sometimes in active lesions. Now this one is an active lesion with gadolinium enhancement. So that can separate out. That will tell you that they can be aged. So there are lesions from two different points in time. So T2 hyperintensities, so infratentorial lesions, juxtacortical lesions, U fibers, and of course the periventricular and the spinal cord lesions. So here you can see the juxtacortical lesions, further elaborated here. Spinal imaging shows these small, short segment lesions, less than 2 vertebral segments usually, as opposed to neuromyelitis optica, which has long lesion myelitis. And they can be enhancing if they are active lesions. So active new lesions can be enhancing. So enhancement might be seen. You can see the enhancement here, if you can appreciate the two different images. Then of course that these lesions occur in perivenular inflammation is fairly characteristic of MS. And you get this so-called central vein sign. And you might see a central venule in some of these lesions in high-resolution scanning, 7 Tesla scanning. Generally, the best imaging world over is 3 Tesla for MS. We are fortunate to have 3 MRI machines in this hospital. 2 of them are 3 Tesla. So we have high quality imaging of our patients as opposed to many, even some international centers, which mostly have 1.5 Tesla machines. Going beyond that, research-based in some centers might have a 7 Tesla machine, which might pick up the central venue better with ultra high field MRI scanners, but these are not available for general clinical usage. However, in certain cases, even with the 3 Tesla machine, these central venules are detected. So this is, you can see that, you can see the lesion with a small central area showing the central venule. So this is with the 7 Tesla machine. So this would be able to, if you see this, you can say these are not NMO lesions or MOG lesions. These are definitely MS lesions. Right. So the presence of the central vein inside MS lesion is, as I said, is well established as a feature of these MS lesions, and we would be able to differentiate it from the other related conditions. So this is a patient whom we had recently, a male patient with multiple periventricular lesions, and there are some, I think, juxtacortical lesions as well. Then, of course, we use this MRI criteria, which goes as the Magnane's criteria. So there are certain criteria used. The latest revision comes from the 2016 criteria for Magnane's. Those are MRI criteria, which can be used to make a reasonable deduction and come to diagnosis. So you can go through these criteria. The 2017 McDonald criteria are the latest that we use. They are looking at revising this, but not yet done. Then, of course, the Magnane's criteria for MRI. So there are certain red flags. So if the MRI brain is normal, it is difficult to make a diagnosis of MS. So because 95% of the patients will have abnormal MRI brain. So without an abnormal MRI brain, to say it's MS is difficult. So you have to be very careful. It can happen in primary progressive MS, where only the spinal cord is affected. But it's not easy. So you have to think twice. And also in the neurological examination, after a few relapses and so on, if you don't find any abnormality at all, it is generally said that MS is unlikely. And also if the patient presents to you with bilateral visual loss at the same time, simultaneously, it's unusual. Usually MS patients come with unilateral uniocular optic neuritis visual loss. Bilateral is seen in MOG disease or MOGADs and some other conditions, but not in MS. Peripheral problems, unlikely. And any movement problems, rigidity, dystonia, unlikely. Seizures, well, MS can present with seizures due to this car epilepsy and so on, but it's not a common feature. So you got to keep looking for any other structural pathology. Might have to sometimes resort to biopsies also if the lesion is big enough. So there's a variant of MS called the tumor-factive MS, which looks like a tumor, and some other variants also, Baylos, Marburg's, and so on, where you might have to do a biopsy actually to separate it out. Then headache, early dementia, symptoms occurring abruptly, of course, it can happen, but it's rather, you need to exclude vascular if it is sudden onset. Cortical deficits, intractable hiccups. Now, if you have intractable hiccups, these other diagnoses that we were talking about, NMO-SD or neuromyelitis optica spectrum disorder, is the more likely diagnosis, because the lesions in the area posterior of the medulla is supposed to be responsible for these intractable hiccups and nausea, vomiting in those patients. So in MS, no intractable hiccups usually. In some cases, case reports may be there. Prior to these diagnosis of NMOSD was clarified in 2004 with the antibody. And the age. If the patient is very young, MS is unlikely. Over 50 to begin with, no, unlikely. And of course, these white matter lesions has a huge list of DDs. So there are so many, as you can see in this. So white matter lesions in the brain doesn't mean MS. So it's difficult because of that. The location is important, clinical history is important, other tests are important, CSF is important, visual evoked potential is important. So everything put together, we make a diagnosis of MS, having excluded the possibility of these things in certain cases. But sometimes the case might be pretty straightforward, but most of the time you have to be very careful. Just looking at lesions in the brain, you can't, because it's quite common for radiologists to give reports of multiple sclerosis. This is a disease which is a degenerative disease sometimes. So because of that, you have to be careful when giving a diagnosis like that without proper evaluation. So this is a huge problem we are having. Looking at an MRI, patients are given a diagnosis of MS, which is not correct. So the brain lesions, as I said, can occur also in other conditions which are similar to MS and MOSD. So this is the problem. So if you have brain lesions in them, you wonder whether this is MS. So they were all MS before 2004. 2004 is the landmark year where this aquaporin 4 antigen was found. Antibody first in 2004, antigen in 2005. But before that, they were all MS. And there was this entity called opticospinal MS, which has gone out of the way now because of this presence of this antibody. We know that it is unlikely that that's a clinical entity anymore. So what is a relapse? MS is a relapsing disorder, as I said earlier, relapsing remitting. So relapse is defined as episode of neurological deficits, functional neurological deficit lasting for more than 24 hours. That's important. With a preceding period of clinical stability of at least 30 days. So that's important. It has to last for more than 24 hours. So there are pseudo relapses. So you have to be aware of these pseudo relapses because then this is a common problem we are having. They are worried about it. They come in search of methylprednisolone injections. They want to get admitted. But you have to ensure that these relapses are actual relapses. So they have to be evaluated. So the relapses could be mild, highly active relapsing. Some patients have highly active disease, relapsing more than twice a year. And some patients have rapidly evolving severe RRMS. Some patients may have no relapses or MR activity for 24 months. Then we call this NIDA, or without any disease activity. So what is CIS and RIS? Clinically isolated syndrome, as I mentioned earlier, is one episode with some MRI lesions and so on, but inadequate to make a diagnosis of clinically definite MS. First clinical episode, event of precedent history that is suggestive, lasting for more than 24 hours. So it's a proper event, but there's only one event, so not enough to make a diagnosis. Some of them might become MS. So nowadays, with the current criteria, CIS also is little by little going out of the way because more and more cases are diagnosed as MS now. Radiological isolated syndrome is more interesting. When you do MRI for patients with migraine or epilepsy or something, you find these lesions which are looking very much like MS lesions in the right places, but they are not MS. I mean, clinically, the patient are not presented like MS. They have come with migraine or something. So they have followed up some of these patients, and interestingly, about 1/3 of them might end up with MS in about 5 years. That's very interesting. So this is a clinically isolated syndrome. Patient presenting with the first clinical episode, lasting for more than 24 hours, and MRI changes, but no definite evidence to diagnose MS. Right. So moving further, primary progressive MS. Primary progressive MS is another entity where you may get progressive symptoms from the very beginning. So the diagnosis here is a little difficult and different. So 1 year of disability progression retrospectively or prospectively determined, independent of clinical relapses. Right. So we'll go into treatment to wind up. Now, how are we going to treat these patients? Once we make a diagnosis, the important point is to make an accurate diagnosis, which is the most difficult thing. Not only in this part of the world where MS is thought to be less common, even in countries where MS is common, this diagnostic process can be difficult. There are many studies and reports of such instances from the Western countries where this disease is common. Still, diagnostic errors are made. So diagnosis is crucial. So that is what we strive to do here in our setup, in our department, to make the diagnosis as secure as possible. And once we make that diagnosis, we have to start treating them appropriately. The initial treatment in all CNS IDDs might be the same because they are immunologically driven conditions, whether it is MS, whether it is NMOSD or MOGAD or ADEM or whatever the initial treatment which we give, immunotherapy as we call it, might be methylprednisolone pulses or immunoglobulins, plasma exchange, rituximab. The initial treatment might be the same. However, what is important is the long-term treatment. MS long-term treatment we do in order to prevent the relapses, hoping that the relapse reduction will eventually reduce the disability, and we have practically seen that happening. So as this mentioned at the very beginning, there have been tremendous advances in this field over the last decade or so, with so many new high-quality drugs which prevents these relapses and allows patients to live normal, active lives. So many such disease-modifying drugs are available to treat MS. In this country, we are fortunate that the Ministry of Health helps us to obtain at least a few of them for our patients through our clinics. These drugs are expensive. However, we have been able to provide this through the neurology units in the country to deserving patients. So there are many drugs. Injectables were the drugs which were used from the late or mid-90s with the discovery of interferon in 93, 94 like. From that point onwards, they were all injectables, glatiramer acetate, natalizumab, and so on. However, in 2010, the first oral drug, fingolimod, was FDA approved. So ever since then, there have been few other oral drugs. Cadribin is there, and teriflunomide, and also other newer drugs, siponimod, and so on. Then also interestingly, progressive MS, 2019 was a very crucial year or a landmark year in the treatment of these diseases because there were so many new drugs, highly effective drugs coming out, FDA approved. So ocrelizumab is the first drug to be used in treating primary progressive MS. We never had a drug for primary progressive MS before that. So ocrelizumab is now licensed to be used in them. Then of course, secondary progressive MS also. Now there is siponimod, which also is thought to be effective. The initial drug was fingolimod. Then, of course, there are other methods of treating them. For aggressive forms, so induction therapy, there are two schools of thought, whether to treat them aggressively by induction therapy using more stronger drugs like alentosumab or natalizumab or cladribine, or the cheaper drug which we have, which is called mitoxantrone. So we have been able to use mitoxantrone in some of these aggressive cases of MS with mixed results, some of them showing great improvement. And right now also, I think we are treating 1 or 2 patients like that. So that is cheaper compared to the other drugs which are in this list. So you can see there are many drugs which are available. This also gives another list of drugs. You can go through these individually. And what is important is with higher efficacy, side effect profile also goes up. So you got to be aware of that, because some of these causes immunosuppression. So along with it, there are other complications that can happen. And for example, the worst complication we have had with these drugs was with natalizumab, which was introduced in 2004-5. It was a landmark discovery kind of thing, because all the lesions started disappearing in the brain scans. So there was so much of hype, but to be found a few years later that some of those patients ended up getting PML. So PML is a progressive problem, multifocal leukoencephalopathy, which is life-threatening. So these problems are there, but of course, this is due to a particular virus called JC virus. So we do titers of these viruses before natalizumab is used now. Then, of course, there are other things about switching drugs from one to the other, various guidelines to take into consideration the patient factors and the response to treatment. If they are not doing well with a particular drug, to move to the other drug. So you can go through these things. I mean, there are so many recommendations given by the American Academy of Neurology. So there are other symptoms that you need to be managing in these patients. Cognition, depression, fatigue, heat intolerance is a problem. And they may also have paroxysmal symptoms, which sometimes, like episodic tonic spasms, carbamazepine helps. And some of these things, and spasticity, of course, is a huge problem. So we use some of these drugs which are well known: tisonidine, baclofen, dantrolene, clonazepam, and so on. So this is for symptomatic management. Other big problem is managing fatigue. Not easy. Many drugs are tried: amantadine, modafinil, and some of these amphetamines and so on, but with mixed results. So this is the new drug for primary progressive MS, ocrelizumab, as I mentioned, and siponimod is also 2019. All these drugs were FDA approved in 2019. And we have one patient who's on this, young boy, who's on this drug. And eculizumab, of course, this was a huge discovery in a sense, because they found that in neuromyelitis optica, they can drastically drop the relapse rates by about 94%. If you drop the relapse rate by 94%, you almost give them a cure in this condition, because this disease is a relapse-based disease, unlike MS, which can still progress in between relapses to some extent. Neuromyelitis optica spectrum disorder is a relapse-based one. So in between, we believe most of the time, there's no progression. So this again is a new drug. So there were 3 drugs for NMOSD also approved in the same year. So assessment of these patients are done through this EDSS score. I think this explains everything for whoever wants to go through this. Starting from 0 to 10. 10 is death, of course. So amount of disability you can measure accordingly. This is very important in following up these patients and ensuring that the patients are functionality of the patient and prevention of various complications. So this further details what is there in the EDSS score. Right. So before I wind up, I will just go through a couple of patients here. This is a 41-year-old male presenting with intractable hiccups, nausea, vomiting. So which was diagnosed as gastroenteritis and treated by an infectious disease team. And then she developed left eyelid twitching. Because of that, she was referred to us. So the left facial weakness and numbness was detected with some twitching, which was there in him. Then, of course, the MRI brain had this lesion here near the fourth ventricle. You can see a lesion and some other periventricular corpus callosal lesions. Spine was normal, but oligoclonal bands are positive. So antibodies were tested. AQP4 MOG antibodies were negative. So this being, having CSF oligoclonal bands positive, brain lesions are there, and the VP was delayed bilaterally. So is this patient having MS or is this patient having neuromyelitis optica spectrum disorder? Because this is very important to separate out. Well, there are many things in support of MS here. The brain lesions are there, periventricular lesions are there. Then, of course, oligoclonal bands are there. Then the antibodies are negative. So it is unlikely to be aquaporin 4 or MOG disease. But having said that, sometimes you can have seronegative cases. But the real catch here is the fact that the patient had presented with intractable hiccups and vomiting going on for weeks. And there is some lesion here, somewhere here, as you can see. So will he become NMO or aquaporin 4 positive later on? So does this oligoclonal band positivity, does it rule out NMO? We know that it is not. So we saw that it's about 26% positive in them, 80% in MS, but 26% in aquaporin 4. So can MS present with intractable vomiting, nausea? We said that it's unlikely. So it's a difficult case. So we have taken a call on this one and started treating him as MS. Right. So just to highlight the difficulty in managing them. So some of these lesions, as you can see, this lesion over here is perhaps something like what he has is thought to be more common in MS. So this is the last case of my presentation. 10 episodes of optic neuritis. So she has had one episode which looked like a transverse myelitis. BP unrecordable on the right. So there are lesions in the brain and the spine, long segment myelitis. 10 episodes of optic neuritis. But again, antibodies are negative, OCBs are negative. But it's important to note that some of these patients may not have the positivity because if they are in remission, you might not pick up the aquaporin 4. So there is a long lesion myelitis, bilaterally involved optic neuritis. This is more in favor of a seronegative myelitis, I would say. So this patient was treated as such. Right, so we have come to the end of my talk. So now I would invite my three senior registrars, Dr. Dunya, Dr. Dari, and Dr. Chulika, who will be presenting to you a few, about 4 cases very briefly. And also followed by that, those is a short MCQ on what you have learned today. Thank you very much. Thank you again. I would like to thank the Clinical Society, Colombo, for inviting me. Thanks a lot. And also we'll take up any questions at the end of all the presentations.
So after the comprehensive lecture on MS and mimickers, I'm going to take you through a case presentation, the patient we came across while in the ward. So let's begin. So she's a 19-year-old, previously healthy, and she was studying for her A-levels like 1 year back. Her first symptoms were when she noticed the vertigo and she found it difficult to concentrate on her studies. And at the same time, she had a right eye visual impairment. So it was said, she thought that it was following a minor trauma. She had a history of a minor trauma to the eye. So then she has gone to the eye hospital and she was managed as traumatic optic neuropathy, and she was pulsed with IV methylprednisolone. Immunosuppressant was given and her vision improved. So that episode passed like that without any other neurology review, or the patient did not come into our attention. And then she has noticed the left facial numbness, which again settled, that is after 4 months after the first presentation. And then the patient developed ataxia and she couldn't concentrate on her studies. Again, this was attributed to the stress. She was awaiting her A-level examination and just this was passed. And then about 2 months after, she developed a head tremor. She had difficulty in walking and speaking. So then they have sought some native treatment for this. Then again, some episodes of worsening of head tremor, and then initially she had unilateral visual loss, but then bilateral, not sequential, but it took a long time for her to develop this bilateral thing. So upon examination, she had a right side RAPD, relative afferent pupillary defect, and I would like to play this video for you to see what is she looking like. So. Yeah, I think you will observe the tremulous, sorry about the quality of the video, but there's prominent head tremors and there is a significant, yeah. So this is, she had a typical MS tremor involving the eyes, head tremors, and bilateral hand postural and action tremors. And she was very ataxic. She was not able to walk by her own. She needed support constantly. And so the line you saw was for plasma exchange, which we have inserted. So with those things, sorry. So we went ahead with imaging with this history in mind and doing several investigations, including serology. We went ahead with imaging. MRI brain was done. So as Sir already mentioned, there are typical lesions involving the periventricular area, multiple lesions. And there were some old lesions in the brainstem and new lesions as well. I don't know whether you will appreciate there are some black holes, which are old lesions in the MRI, and some new lesions as well. So she had a history of optic nerve involvement, which was diagnosed as optic neuropathy or neuritis at that time with objective evidence initially. And this time she had cerebellar symptoms, and there were compatible MRI lesions at this time as well. So her MRI spine had multiple short segment myelitis. So I think you can remember the diagnostic criteria. 2017 McDonald criteria was fulfilled easily because she had 2 clinical attacks, more than 2 clinical attacks, actually, with objective evidence of involvement of the relevant areas. So with that, we came to a diagnosis of RRMS, relapsing remitting MS, which is the commonest type of MS. So in this case, I would like to highlight the clinical cause of MS. So as I already said, most of them are relapsing remitting. So you can see there are relapses, then the patient is better, then she goes on relapses, as in typically our patient fitted into this criteria. She is fitting into this criteria. So she's currently in the ward being managed initially with IV methylprednisolone pulses. With poor response, then we went ahead with plasma exchange. So for remission induction, and then we have completed 7 cycles of plasma exchange, and she's awaiting mitoxantrone, as I already said. So yeah, so I just wanted to highlight the typical cases we come across daily in the wards, and it's important to miss these patients in the initial presentation where she presented with vague symptoms. She might come to one of you all in the future. So as future doctors, please always suspect, because we have to intervene early to prevent progression of the disease and to prevent disability. So I want to encourage the senior registrar in our unit to take you through the journey of another patient. Thank you so much.
Thank you, Dr. Punya, for that introduction. So I will move on to showcase another subtype of multiple sclerosis with this case. So this was Mrs. S, a 30-year-old university student. Her disease started in 2019 January, where she had difficulty in walking due to bilateral limb weakness. And at the same time, when she presented to us in July, that was 6 months later, she also had blood involvement and as well as severe depression. But I want to highlight the fact that digging into the history in 2014, that was when she was 24 years, had an episode of transient numbness evaluated on its own. So this was managed with high-dose intravenous steroid pulse therapy, and then she was followed up at the neurology clinic. However, this patient had poor, defaulted treatment, and also there was some unavailability of the disease-modifying drugs, unfortunately. So the disease actually progressed. So initially it had this relapsing remitting nature, but it worsened steadily towards the latter part of the year. So by December, she was virtually bedbound, according to that previous what Sir mentioned, that EDSS score was 9. So this time she had to be put on very high-end therapy, that with IV mitoxantrone, but she had very good response to that. So she could walk without support once the treatment was completed. However, again, there was a period of default, highlighting the importance of proper follow-up and also using the disease-modifying drugs early on to prevent such episodes. So in 2021, that is this year, currently she is admitted to our ward, again with recurrence of this bilateral lower limb weakness, and currently, again, she is bedbound. So this is her story. With the signs and also vision. So we went ahead with the investigations. The visual potentials were unrecordable in both eyes. You can see how it is done. Like they use this checkerboard stimulation, and with that they have electrodes over the occipital lobes where they record the impulses. So if there is any pathology affecting predominantly the anterior, areas, it can be bilateral visual pathways has been affected in this patient. So the MRI imaging, you can clearly see on your right-hand side, there's drastic volume loss in his brain. The ventricles are very much dilated. So according to the age, there's considerable atrophy due to this default therapy and the lack of early disease-modifying drugs and the severity of the disease. So the whitish areas demarcate the pathology, that is the demyelinating area. So this confluent demyelination can be seen in the periventricular regions. And also this other yellow arrow in the top, you can see the pontine involvement, as well as there are several cerebellar lesions, so which fulfills the Magning's criteria. And also on the left-hand side, you can see the upper cervical spinal cord has several short segment myelitis, which is again compatible with the diagnosis of multiple sclerosis. So the CSF oligoclonal bands were positive and the NMO screen was negative in this patient. So the diagnosis was made as secondary progressive multiple sclerosis due to the steadily progressive nature of her illness. So the treatment-wise, we started her on IV methylprednisolone as well as mitoxantrone. And as for the disease-modifying agent, at the moment we have we are planning to start her on fingolimod or siponimod according to the availability. For the interest sake, I have put this figure on the right-hand side. That is, this is a fungus actually, from which this fingolimod was actually found initially. The invention was through that. So this is a fungus which is a sort of a parasite growing in insects. So that was how this fingolimod was found out. And that was of the drug therapy, and which we should not forget is mainly the rehab part. The initial video you show, one of the doctors who were patient spoke about this. So the rehabilitation is very important in managing these patients, particularly because they are having a lot of disability. So the physiotherapy, occupational therapy, as well as bladder bowel care and swallowing assessment is a must. And also the psychiatric support to the patient and the family. This shows this, the green arrow shows this patient's disease subtype progression. Like initially it is kind of remission relapsing, but later on it is steadily progressive, which makes the diagnosis, we can diagnose her as secondary progressive multiple sclerosis. So with this, I will wind up this case, to be followed by two other more interesting cases, which will showcase another variants of MS and mimics. Thanks.
Thank you, Udari. We come to the third case presentation today. I hope you can see this video and try to identify the clinical sign that is demonstrated in this video. So this is a young girl, around 30 years of age, and she came with sudden onset of diplopia. So what you saw here is actually internuclear ophthalmoplegia, that is bilateral, as in this video. Internuclear ophthalmoplegia can be unilateral or bilateral, but in this girl, she had bilateral internuclear ophthalmoplegia. So what happens is normally when we look at horizontal, when horizontal gaze is provoked, there are two muscles actually come together which carried out this movement, that is medial rectus of one eye and the lateral rectus of the other eye. So what happened in internuclear ophthalmoplegia is the adducting eye failed to adduct, that is the medial rectus failed to adduct, whereas the abducting eye, the contralateral abducting eye create nystagmus. So the pathophysiology is actually in the medial longitudinal fasciculates, which starts below the posterior commissure and ends in the upper cervical spinal cord, and it involves in the conjugate eye movements. It connects ipsilateral third nuclei, which is responsible for the adduction, with the contralateral sixth nuclei, which is responsible for abduction. A lesion in the MLF results in impairment of the ipsilateral adduction and normal abduction in the contralateral eye with the nystagmus. So what are the causes of unilateral INO? As you saw here in this girl, multiple sclerosis and brainstem lesions such as vascular infarctions, tumors, aneurysms, infections, Wernicke's encephalopathy, and drug overdose, any of those conditions which affect the posterior part of the brain can cause unilateral INO. But here in this video, you saw bilateral INO. I wanted to highlight the fact that if you see a bilateral INO in a young patient, you should think about multiple sclerosis, as bilateral INO is commonly caused in multiple sclerosis if the lesions are in posterior compartment. Which brings me to my fourth case presentation. This is about another girl that we saw in our ward. She's Miss D, who is 30-year-old girl, and she presented to us 10 years ago with sudden onset of right side visual loss. And in this episode, she was treated as optic neuritis, and she showed a good improvement with IV methylprednisolone. But she did not have any other associated neurological weaknesses. 5 years ago, she again presented with left side sudden onset blindness. So again, she was treated as left side optic neuritis with methylprednisolone. And at that time, I want to show you MRI brain. As you can see, there are many multiple lesions are seen, periventricular, cortical, and juxtacortical lesions. So if you listen to Sir's lecture, there are diagnosis criteria of diagnosing in MRI lesions of MS, which should demonstrate dissemination over time and space. In this patient, she fulfilled all these criteria. In this MRI spine, you can see some of the short segmented myelitis lesions in this patient. So in 5 years ago, we diagnosed her as multiple sclerosis and started on disease modifying treatment. However, she did not improve. She actually became worse. So we were thinking, what was the cause? Actually, 3 years ago, she again presented with visual impairment of the left eye along with the left side lower limb weakness. Her VEP showed bilateral absence and CSF polyclonal bands were absent. And if you listen to Sir's lecture, it was mentioned that other serological antibodies are must in diagnosing MS, because if one of those antibodies were present, that exclude the diagnosis of MS. In this patient also, we found out that her MOG IgG antibody was positive. It was available in 2018. So we shifted her diagnosis to multiple sclerosis to MOG IgG disease. So now she is on oral prednisolone and she's doing well. After that, she did not come with any relapses. So from this case, I wanted to highlight the fact that multiple sclerosis in other demyelinating disorders such as AQP4 and MOG disease can present as multiple sclerosis. So the investigations, the line of investigation which you heard earlier, including these antibodies, are very much important in diagnosing MS. So after this case presentation, there's a short quiz that we have prepared for you. There are 5 MCQs actually. You will be given a half a minute to answer each questions. and we will demonstrate the questions for you. Then we'll go through the answers. So this is the first question. Multiple sclerosis as a disease was first described by Eugene Devick, Ian MacDonald, Jean Martin Charcot, Charles Bell, and Wanda Lennon. You can start answering now. If you paid attention to Sir's lecture, these MCQs will be very easy. So 79% has given the correct answer, which is Jean Martin Charcot, who has described the multiple sclerosis back in 1868. And also he was known as the father of modern neurology. So we'll move on to the second MCQ. Which of the following investigation will not help in the diagnosis of MS? Contrast MRI, visual evoked potentials, CSF oligoclonal bands, CT brain and spinal cord, CSF IgG index. So again, most of the candidates have answered correctly. 62% actually CT brain and spinal cord is the correct answer. Because CT, especially non-contrast CT brain, has low positive predictive value in diagnosing MS lesions. In contrast, MRI, visual evoked potential, CSF OCB, and CSF IgG index actually help in diagnosing of MS. We'll move on to the third question. Which of the following is not a central nervous system inflammatory demyelinating disease? First one is acute disseminated encephalomyelitis, sarcoidosis, multiple sclerosis, neuromyelitis optica spectrum disorders, and transverse myelitis. Um, 77% has given the correct answer, which is sarcoidosis. As you have correctly answered, all the other diseases which are mentioned here comes under the term of CNS IDD, CNS inflammatory demyelinating disorders. But in contrast, sarcoidosis is a granulomatous inflammatory disease in CNS. The fourth question is, which of the following is not a typical site involving in multiple sclerosis? Basal ganglia, juxtacortical, cerebellar peduncles, periventricular, and optic nerve. Majority has again answered correctly, which is 53%. Basal ganglia are uncommon site of demyelinating lesions in MS, but other sites that have been described are well known to occur in MS. Which brings me to our last question for the day. Which of the following is not a typical clinical presentation of MS? Bilateral INO, cerebral syndrome, segmental optic neuritis, and bilateral trigeminal neuralgia. Actually here 45% have answered correct, which is long segmented myelitis. If you were paying attention to the presentation early, it was described that short segmented myelitis are the characteristic lesions in MS, as in long segmented myelitis can be seen in other demyelinating disorders such as Morgan AQP4. The other syndromes which have been described are typical of MS. So thank you for participating in our session, and I will hand over presentation to Enoka.
I would like to thank Dr. Bimsara Senanayake for his very comprehensive presentation on multiple sclerosis and his team of senior registrars for interesting case discussions. And his team of senior registrars for the interesting case discussions and the multiple choice questions. We would now like to open the floor for any questions. So the participants may submit their questions to the chat forum, and we will be taking up your questions. We will also be taking questions from the live audience, so the live audience can also submit their questions. Okay, so we have a few questions. So I would like to forward these questions to Dr. Sir, our first question is, why is multiple sclerosis seen more commonly in temperate countries? Is there any reason as to why we see this kind of geographical distribution of this disease?
Actually, the question was about the prevalence rates being different in different parts of the world. Why is it more common in temperate zones and away from the equator and the latitude gradients and so on? The geographic variation in this disease. Actually there's no definite answer to that question, but there have been various other possibilities like environmental factors and genetic factors which may be contributing towards this. And also with the migration, it has been found that certain individuals who migrate prior to them attaining puberty might have a higher risk of getting these diseases if they go from a low prevalence area to a high prevalence area. But there's no definite reason associated with it here.
Okay, thank you, sir. So we have a few more questions. Our second question is,
Which disease-modifying drug do you recommend in relapsing cases of possible multiple sclerosis, where the investigation facility for doing the oligoclonal bands and the antibody testing is not possible? So basically, which disease-modifying drug would you recommend where the diagnostic facilities are not readily available? This is the question.
Well, it's not. I mean, you cannot choose between different DMTs based on a diagnosis being not made properly. The question is like whether you could diagnose MS in the absence of oligoclonal bands. Yes, you can, because some of our patients also may not have oligoclonal bands. It is thought that about 80% of patients worldwide do have oligoclonal bands in their CSF, if properly tested with the isoelectric focusing method. However, we find in this part of the world that rate is around 50%. Maybe it's a regional thing. So that is not entirely essential if the patient satisfies the criteria without the oligoclonal bands. So that is one thing. And then secondly, you said that in the absence of antibody testing, of course, these antibody tests are not freely available. So antibody tests are not actually done in all the patients all over the world also. So it's not freely available, but if they are available, it's very good to do. But what is important is to try and fit in the patient into the criteria. So with the criteria, whether we would be able to make a diagnosis of MS based on, in the absence of oligoclonal bands, maybe the clinical history or maybe the MRI might act as a surrogate to help us to make the diagnosis. So you have to fit the patient into the criteria and make a definite diagnosis based on the criteria. It's good to have the oligoclonal bands, of course, but the patient might have spinal lesions as well as brain lesions, which adds up to what we are thinking, maybe sometimes. And also aging the lesions. Maybe you might have active lesions from a different age, so dissemination in time and place. So that's what we are trying to prove. So having made the diagnosis, it is entirely up to you and with discussion with the patient and of course availability to decide on which one to use, the DMT, disease modifying drug. So it is based on the severity of the problem, frequency of relapses, how bad the MS is, whether it's severe, relapsing, acute MS, based on things like that, the severity. And so the diagnosis, of course, doesn't determine which one of the DMTs that you're going to use, because the diagnosis should be secure.
Thank you, sir. So we have one more question. The question is, what condition do these patients ultimately succumb to? So in other words, what is the most common cause of mortality in these patients?
Yeah, that's a good question. Actually, they can, of course, now, as mentioned earlier, we have a rating scale or EDSS score where we sort of grade them according to their disability. So close to the other end of the spectrum, like 8, 9, 10, like the patient, I think, Dunya presented. So these patients can be pretty disabled. I mean, they can be having bed bound. Sometimes they are unable to move around, even with support. So in such cases, maybe the patients develop more prone to get infections, secondary infections, bed sores, and various other complications, and also venous thrombosis. Secondary causes usually, because these are young patients, so generally they are otherwise well in most of the time. Like most of the time they are otherwise well. So they die maybe due to complications as a result of secondary infection or disability related venous thrombosis, pulmonary embolism, things like that. Apart from that, there's no, they can always get the other metabolic complications and other various other disability-related problems are the main reasons, I suppose. And of course, they have sphincter control problems. Urosepsis is a common problem that they have. Yeah, so.
Thank you, sir. We can take one last question. And sir, the question is, what is the difference between clinically isolated syndrome and the first episode of multiple sclerosis?
Yeah, that's a very important question. Now, actually, the first episode, we call it the first clinical episode of a CNS IDD. That is central nervous system demyelinating disorder, idiopathic demyelinating disorder. That's the first episode. So at that point, you can't say that it's the first episode of a MS. It could be a first episode of the MS also. What I tried to explain is that now, earlier with the previous criteria, they may qualify as CIS because there are brain lesions and some other features like maybe oligoclonal bands and so on, which might look like MS, but not enough criteria to make a diagnosis. Because as I told you, it's important to stick to the criteria and come to a diagnosis, because we put a lot of things together to make the diagnosis. But with the current criteria, oligoclonal bands are taken as an important feature dissemination in time. So we would be able to make a diagnosis. So strict cases of pure CIS is increasingly becoming less now, because we are diagnosing more cases of MS with the current criteria. So, well, the answer is yes, some of those CIS cases could be early first symptoms of a future MS.
Thank you, sir. And that actually brings us to the end of the Q&A session. So we thank you for your comprehensive discussion, your brilliant overview on multiple sclerosis, and for being kind enough to answer all our questions. So once again, thank you. And we will now move on to the next segment of our program today.
Thank you so much. Thank you once again for inviting.
Up next, we have the president of the Multiple Sclerosis Association of Sri Lanka, Professor Enoka Corea, who will now address the gathering. And now, without further ado, I would now like to call upon Professor Enoka to share with us her insights.
Good afternoon, everyone, and thank you to the UCCS for inviting me to give this brief talk, just to share a few slides with you on what the Multiple Sclerosis Association of Lanka does. Okay, so basically, what MSAL does, the Multiple Sclerosis Association of Lanka, is community activism in MS. And we hope that this will prove a kind of model for other chronic diseases and conditions where patients can get together with or without their clinicians and work as activists to bring more attention to the problems that they face. A disclaimer, we have permission from our patients to show these photographs to you. So MSAL is a patient-driven support group for people living with MS. You heard from Dr. Hitaishi Virakun earlier, and as you know, she founded this association in 2006 when she met so many patients waiting in the waiting rooms at various clinics who had MS and felt they were all alone, that they were perhaps the only person with this disease in Sri Lanka, and with very little support systems for them, and completely ignorant about their disease. So basically, the MSAL brings together persons living with MS, doctors, their caregivers, their most important people in their lives are their caregivers, and other well-wishers to promote the optimum health and improve the lives of persons living with MS. And this is our logo. You saw it before. And this is our motto, which is getting the most out of life. And this is the committee, which changed somewhat, but it's a very informal group because most of us are in fact classmates and friends of Dr. Hitaishi Veerakun. But we have added to this number now, we have Zonta activists, we have patient caregivers, and even patients themselves joining us as committee members. So what does MSL do? So we hold patient meetings. I think that's the most important part of what we do. So we have patients and their caregivers and their families coming together, getting to know each other, because they often feel isolated, very isolated, that they are the only person, but now they know they are part of a community, a group that are bound together by this disease, you would think. So during these meetings, we bring in neurologists or other experts to talk to them. It could be physiotherapists, it could be counselors, and that helps them, to educate and instruct people. It's not just we also invite our patients to talk to each other. So this is a very lively girl who has set up a card industry. She makes beautiful handmade cards, and she instructed the others, and she's trying to help them set up, employment, self-employment for themselves as well. So important things like how physiotherapy is done and exercises that are useful to maintain body strength, core strength, and flexibility. We have demonstrations like that to educate our patients, and of course it provides an opportunity for the patient to ask questions and get advice and from and caregivers as well, to ask about the things that worry them about their patient. So it's not just in Colombo. We have a branch in Kandy, and we go up to Kandy regularly to hold meetings there too. It's not just talks all the time. We have entertainment. This is an origami sort of a workshop one day to try and help people to help, improve their fine movements by doing things like origami. There's music therapy we had once, and we have sing-songs and dancing and movies and things like that as well sometimes for the patients to enjoy. We also celebrate the annual World MS Day with a major program with colorful invitations sent out to patients. And we have very eminent guests. We have had many SLMA presidents addressing our patients on World MS Day, and even the Secretary of Health. And you can see our former dean too. She was very helpful to us. And of course, we have Dr. Bimsara and Dr. Arjuna, who are our medical advisors. So these World MS Days are very enjoyed by people, and it's actually a celebration with flower arrangements and beautiful tablecloths, and we end up with a meal for everybody. Right. Then we also try to educate the people living with MS, because as I told you earlier, they are very confused. They are very, they do not understand what has happened to them, and it's all above their heads. So we have, simple sort of information in both English, Sinhala, and Tamil that we try to publicize among our members. We have a Facebook page that they can access, but though unfortunately not very many of them seem to be IT savvy. We have lots of other people visiting our page, but I think the patients are less. But and certain information and resources that are out there, we have translated them to Sinhala and to Tamil also for, so that they're more accessible to our patients. We also do patients assistance, of course, provide things like air mattresses, wheelchairs, and other crutches and other things that are needed. Some people gave us some dry goods that we distributed recently. We even built a house, or rather the person had been given a house, but we plastered it and put electricity and things like that. So we have special projects where we, this is an MS mother with 3 children. They were very young at that time, and there was no one to help them. So we managed to raise donor funding to equip their house so that they could live there comfortably. I think one really important thing that we do that really needs to be rolled out perhaps in other neurological and other chronic diseases is home-based needs assessment. So we have a very enthusiastic occupational therapist, trained occupational therapist who helps us, Mr. Kitsiri, that you might meet sometimes in the hospital also. And he visits each person at their home and does a home-based assessment. He teaches the caregiver how to lift or how to look after a patient, and and how to manage patients, especially to maintain flexibility and to strengthen the patient's core muscles, and because many of them will end up spastic if they don't have passive exercises and active exercises. So the occupational therapist visits, we try to, of course, with the pandemic, this has come to somewhat a halt, but this weekend he visited a new patient of ours in Kalatur who just rang me and was so happy because he said he learned so many things in the 2-3 hours that Kitsiri spent with him. And we don't really realize the big gap between what we know and they know. You'll be amazed if you sit and listen to a lay person, the huge gap between what we know and they know, and we just think it is a given. I mean, they should know physiotherapy is good. They should know this. They should know what to eat. They should know, but they don't really know that unless we go and help them. And it should be done preferably at home. We also raise awareness on MS, as Dr. Bimsara pointed out earlier. When we started out, 15 years ago or more, even ophthalmologists were not very aware of multiple sclerosis. So we put up these type of flyers that we were distributing through actually Bowers helped us by their drug reps. We used to go and deliver these to all the hospitals throughout the country to try and educate people on MS, because as Dr. Bimsara said, we really thought it didn't exist. We had a session at SLMA when Professor Vajradhya Senanayake was the president of SLMA, which was well attended. We have a desk always at the ASN sessions annually to try and raise awareness about our association. Then among the public, we have articles in English, mostly in the English language newspaper, but also in the singular language newspapers. We need to go into Tamil, especially on World MS. Around World MS Day, there's always something on World MS in the newspapers. Then we have tried to educate other associations like Zonta and the corporates. We produced a newsletter, not a newsletter, it was more leaflet, an educational leaflet that we rolled out into the public. And you can see here people distributing these leaflets to educate the public on MS. One of the best things we did was have a walk. We had a awareness walk in 2017 as part of the World MS Day. I think Dr. Bimsara also showed this photograph of the walk. That was a really successful morning, I think, enjoyed by all, by the well-wishers, the patients, the caregivers, and the public. And that raised a lot of awareness at that time. Here you see Dr. Bimsara chatting to Hitaishi Virakun. And of course, there's today, we are so happy that World Brain Day 2021 is dedicated to stopping multiple sclerosis. We also do patient advocacy, and we have had some high-powered people visiting us. This is the former Secretary of Health, Dr. Anjita Tapattu. We had even the former president, when he was Minister of Health, he attended one of our meetings. And of course, we had a tremendous support from ASN, especially Dr. Bimsara and Dr. Arjun Fernando, and we finally managed to get treatment for MS as part of the regular, rolled out as normal treatment of in the state sector, free of charge in the state sector. That was after many, many years of lobbying, because there was such a turnover of health ministers and secretaries. It took, lots of cycles of lobbying to be able to do what Dr. Wimsar talked about today, that is give our MS patients treatment in the state sector at government expense. We do some fundraising over the years just to, do our activities. This is Dr. Manla Joseph, a pathologist, who did a show for us once. But let me just close by saying, things are still not very easy for patients with MS. They're from rural areas, many of them, as you heard, diagnostic procedures lengthy and expensive. There's limited access to healthcare. I mean, in a wheelchair, anyone with disability in Sri Lanka, to get from out of their house and into healthcare, there's many, many obstacles on the way. They don't have much access to MS because everything out there in the internet is either technical or in the English language. So we need a lot more translations into Sinhala and Tamil. They have a lot of coping problems because with the chronic, this is a young person, often a young woman with a incurable, what she feels is incurable disease. These are not things easy to cope with. The other horrible thing is that in Sri Lanka, a lot of patients are kept hidden, and when they are, and when many people view that as that this disease, this chronic disease, is a kind of a karma, or it is due to some past sins, and that it's up to the patient to just enjoy it because it is their fault almost. It is their fault that they have got MS. And even Dr. Hitashi Virukon had that experience where a neurologist told her that, it is after all your karma, you must have done something in the past that has made you, given you this MS, and you have to, just endure it. So those are very difficult for patients to cope. And of course, there's very negligible support from the state for any of these disabilities in the community. And lack of community care. So first of all, I would say, we really need to break the stigma and ignorance. And as Dr. Bimsara said, there's thousands more patients out there that need to be diagnosed, but they will not come forward to be diagnosed if there is stigma and if they face rejection. So we would like MS to be better recognized by the Ministry of Health and by all the healthcare workers, increased awareness among the whole, the healthcare workers and the general public, some preferential treatment of these people with chronic diseases, not just MS, but there are so many out there. Like, they need a lot of rehabilitation, they need a lot of physiotherapy, they need to stand in long queues sometimes to get there in clinics. They just cannot do that. Or even in the private sector clinics, they need some kind of preferential system to fast track this disabled people to access what they need quickly. And of course, I think what we really, really need is something out in the community there. So we need social services and the health ministry to get together to ensure, that these people, sometimes they are breadwinners of the family, so they need disability allowance. The caregivers need training and support. Their housing and infrastructure has to be improved. We need, they need to get transport to go to wherever they want to go, whether it is a MS meeting or to the hospital or to a wedding or a funeral. They are sort of stuck at home because it's so difficult to transport them on public transport. So ideally, it would be a better public transport that supports disabled and elderly people to travel here and there. And we really do need a visiting service for these patients, visiting MS nurses as they have in other countries, community-based physiotherapy, occupational therapy, and setting them up for self-employment and other ways to make their lives, for them to earn their own living and improve their quality of life. So thank you very much to UCCS for allowing me to speak to you today. And we do hope that all of us can get together and support these people living with MS. Thank you very much.
Thank you, madam. And I would like to thank Professor Enoka Corea once again for her insights into the excellent work done by the Multiple Sclerosis Association of Sri Lanka. And with that, we have come to the end of today's World Brain Day program, which was organized by the University of Colombo Clinical Society in collaboration with the Association of Sri Lanka Neurologists. So we've had a very comprehensive program today, spanning for over 2 hours. We've had an experience sharing from Dr. Hitaishi, followed by a very comprehensive presentation by Dr. Bimsara, followed by 4 case discussions and a MCQ session. And a Q&A session. And of course, we heard we got an overview about the brilliant work done by the Multiple Sclerosis Association, the work done by the Multiple Sclerosis Association from Professor Corea. So once again, I would like to thank all of the participants for their active participation in today's proceedings. Once again, thank you to all the organizers and the organizers from the Clinical Society and the Association of Sri Lankan Neurologists. With that, we would like to wind up today's session. So thank you all once again, and we hope to have you yet again with another program organized by the University of Colombo Clinical Society. So till then, good evening and stay safe. Thank you.